Excited to finally talk about this service and the rate increases. So we have a lot that we're going to get through today. And while we're going through the presentation, I recognize there's going to be a ton of questions, and that's okay. We certainly encourage questions. We want them because that's how we're all going to learn about this rule. But I do ask that you put them in the chat, and I'm going to address the questions at the end, only because there's so much content that I want to make sure that we get through first. It may answer some of your questions, so if you could just hang tight, I would appreciate it. And if we don't get to your questions, I promise we will circle back at some point. This is just the first of many opportunities for us to learn about this rule and provide technical assistance. So with that being said, here is our agenda for the training today. But before we jump into that, I just want to take a moment and have us all recognize the impact of what is about to happen in January and how we are all a part of something that is very significant, and it's an important moment for all of us to recognize in the state of Ohio, as well as for those individuals who are receiving services on this waiver. So for context, currently, as you all know, the Tier 1 for the assisted living waiver is $54.76. Tier 3 is currently $76.67. These rates that we're going to talk about too shortly are going up to $130 a day. So for Tier 1, that's over 137% increase. And for the Tier 3, that's over 70% increase. So this is a really big deal. I just want that to set in for all of you, because I know that there's been over the years asks for this rate increase, and it's finally arrived in conjunction with this memory care service. So please, when you're having a hard time, I just want you to come back and remember how important this is for our providers, for our individuals, and just for the state as a whole. We're going to be going through lots of different things today. So just keep in mind too that this is the initial rollout of this service, of these rates. And so our goal at ODA was to get the payment rate for all of our eligible providers by January. Again, pending approval from CMS, these rates will go into effect. So we want to make sure that during the presentation and moving forward that we encourage you not to think about hypothetical situations, that we really just focus on the providers who have already sent in attestations and work with them to solve some problems that may arise. Of course, as always, I'm going to ask for your help in identifying trends and issues that are arising come the new year and into spring. And so that's going to help us inform the best way to operationalize this, to monitor this, provide additional training. At the end of this training, I'll be able, and then there's one on Friday for the clinical team. I'm going to be thoughtful in some of the questions that you pose to help inform the training for the providers. So know that that's another step in the works as well. Also, throughout this training, I just want you to keep an open mind. We want you all to be as flexible and as possible when we're going to be working with our providers. We want to find a way to get to yes with them instead of a no. I know we all have our compliance hats on all the time, but this is going to be a different approach in a lot of ways. So we're not going to be interested necessarily in punishing any failures by the providers. We really want to just accept that there are going to be mistakes along the way, and that we'll be able to learn from them and, again, help us inform how we can create better quality of care for the residents and make positive policy changes. So I just wanted to set that tone before we get into the rest of the presentation. So we're going to review changes to the service rule and also walk through in detail the memory care rule, how this new service rule impacts HCBS, We're going to go over the notice that was published yesterday, and then just talk about the next steps with conducting on-site reviews. So the assisted living service rule will include the memory care requirements. So there is not going to be a separate rule for memory care. It's all lumped under the current assisted living service rule. There are going to be two certification types in this service rule: basic, memory care, or both. Certified memory care providers must comply, and this is important to note, that any memory care service provider has to comply with the basic and then all of the memory care requirements. Some of the changes in the current rule right now include the removal of this paragraph A1BV, any maintenance required under Rule 370116-15. We removed this language because it's going to align with the assisted living waiver language, but also because the requirement for maintenance is already captured in another portion of the rule. So it was duplicative, and just to clean up the rule, we took the chance to remove that language. So it's not removing any of the requirements, it's just cleaning up the actual verbiage in the rule. As a side note too, I did attach the memory care rule to this meeting, so feel free to follow along with the actual rule while we're going through the presentation if that's helpful. The next update to the rule is that the language of the resident call system was removed in the definition section. Again, it was a duplication. The requirement already exists within the rule. And is in 3701-16-01, which is covered in another portion of our assisted living rule. So again, just taking the chance to clean up the language and get rid of any duplicate information. Memory care means a service that a provider provides in compliance with paragraph D of this rule to an individual with a documented diagnosis of any form of dementia. This language is pulled directly from the rule and is the definition of what memory care means within this service. So this is a service that is going to be provided to individuals, permitted that the provider meets all of the requirements in paragraph D, which we'll get into a little bit further. What are the basic requirements just for your assisted living without memory care? So reviewing those requirements include that the provider shall display which certification they have on their website. So if a provider has a certification for basic, for memory care, or for both, as they are required now, they need to include that they are certified to provide our waiver services. And now with the addition of the memory care service, we're asking that they include that language on their website as well. You'll see throughout the entire rule that we have removed the private resident unit language, and we've replaced that with resident unit being a single occupancy resident unit. That was just to ensure clarity on what our definition of unit or room actually means, that it's single occupancy. Of course, that doesn't apply to when there's situations of roommates, but that's a separate conversation. But you will see that change in the rule. We've also updated our long-awaited lock language in the assisted living rule. So the resident unit has a lock that allows the individual to control access to the resident unit at all times, unless the individual's person-centered service plan indicates otherwise. So we've removed the requirement for a physician's order to determine whether a lock is required or not. This aligns with our HCBS setting requirements in two ways. One, that every individual is required to have a lock on their door. And then two, that if a modification is needed, the person-centered service plan or care plan needs to indicate that the individual has had a conversation with their case manager and that the case manager has reflected the modification. And there are several requirements for that in PIMS. So we hope that there are no more questions, or not that there can't be questions, of course, but we hope that this language cleans up the confusion that was around it, and again, just aligns with our goal of having person-centered approach, and that the providers understand that they need to work with case managers to input any modifications to this requirement. The last bullet here, other minor updates were made to the service rule, and you'll see that throughout. And that was, again, just to clean up some of the language. Nothing that is significant or will change any of your processes as they currently are right now with the basic service. So let's jump into memory care. This is paragraph D in the rule, and we're going to start at the top. So memory care standards, which are also the memory care requirements, is that we have a purpose statement on the website about the memory care. So if you have a provider who has a basic service and the memory care service, we would expect that the provider, on a very high level, talk about the difference between the two services. If the provider only has memory care, we would again expect the provider to have some sort of statement about what is being provided. We can't provide guidance on what we expect exactly at this time because we want to see how providers intend to meet that rule. So we will be working closely with all of you. We'll be working closely with providers as questions come in to determine what is appropriate or not. And we also expect that you can use your professional judgment and work with the provider and determine whether or not that's going to meet the intent of the rule. But again, we want to ensure that the website is displaying just some general information about this service so that individuals who are considering this memory care service have a sense of what they are offering. Next standard in paragraph B, provider designates the single occupancy resident unit of this rule to be a standalone memory care unit, a memory care unit in a memory care section of the RCF, or a memory care unit in an RCF of a provider that provides only memory care. So that's a lot. Let's break this down. Basically, what this is saying is that the memory care service can be delivered anywhere within the facility. The memory care service does not need to be provided in only a secured or locked unit or wing. The intent is for this service to be delivered to as many individuals who have a documented diagnosis of dementia as possible. We did not want to restrict providers from only providing this service in locked or secured areas. We wanted to give providers the flexibility that if they wanted to, they could provide the service throughout different parts of their facility, only one part of the facility, provided again that they can meet the requirements that we're going over right now. So this is just a fancy way of saying that the service can be delivered wherever the provider chooses, as long as they are going to meet the rest of these provider requirements. Now, how they meet that is going to be very dependent on the provider.
We have to review anyone who has memory care in the first 6 months. So if we get like one rando.
Shelby, can you ask that again?
Do we have to review every memory care person in the first 6 months, or is it just okay? So if a provider has like just one person who's memory care, are do we need to move them and review them in the first 6 months?
Review the individual.
Right. Your one, we got a document the other day, I think it was yesterday, that said, oh, on-site visits, ODA understand providers to be certified to provide the memory care service prior to an on-site visit, but to have the rates effective on January 1st, on-site visits will be conducted to validate compliance with requirements. Providers who are certified to meet the memory care requirements will require an on-site visit within the first 6 months of 2024.
Correct.
So when I read that, I was thinking like a memory care unit or something. But now we're going to need to see if anyone has like a single memory care person and get them done in that first six
Uh,
months.
Not necessarily. We can talk more about that at the end.
Okay.
Because I don't want it to get confused with rolling out that part of the process.
Okay.
Because I just
Sorry.
want to talk, no, that's okay. I just want to talk about the rule and then we could talk about monitoring and oversight
Okay.
next. But we will definitely answer your question. So that's the intent of this paragraph, is that it's going to be delivered anywhere. Now, again, operationalizing it, monitoring it is going to look very different depending on the circumstances of the provider. Next paragraph is that the provider provides or arranges for at least 3 therapeutic, social, or recreational activities that are listed in the Department of Health rule, which we already have for the basic service. But this is per day with consideration given to individuals' preferences and designed to meet individuals' needs. So the big difference here between what is already required in rule for the basic service and what is now required in the memory care service is that we are calling out the amount of activities, which is at least 3. So what that might look like is an activity calendar that includes at least 3 activities for those individuals who are receiving the memory care service. Versus what we currently see right now is sometimes 1 a day, 1 every other day. So the providers are going to have to ensure that they have staff who are going to provide at least 3 activities. Moving on, the next standard is that the provider ensures safe access to outdoor space for individuals. Safe access to outdoor space is going to mean something different for every provider. There is not going to be a one size fits all for this. So for example, this might mean that a provider who already has a secured unit and they have certified AL waiver rooms on that secured unit, if they already have an outdoor space within that unit, that provider is going to be able to utilize that differently than a provider who has outdoor space that isn't within that secured unit. So we're going to have to think based on the provider's physical layout currently. We're also going to have to think about how the individuals um, have this reflected in their care plans. So with the clinical team, you might have individuals who aren't interested in going outside. So working with how to ensure safe access to outdoor space might look very differently for that individual. We might have to collect a census on or a consensus on the amount of individuals who are interested in going outside and what time of day. So again, this is not like all of our other rules where it's stamped out and one size fits all. This is going to be based on lots of factors, which we will figure out together, I promise. The provider, I'm sorry, next paragraph E, the provider assists each individual who makes a call through the resident call system in person in fewer than 10 minutes after the individual initiates that call. Nowhere else in rule, there's no federal requirements for call light response times, but we put this in rule because based on survey response from existing providers, most of them already do this. In terms of monitoring this, providers have the ability to utilize electronic systems in place already. There might need to be some manual checking of this. But again, how we monitor this and how we operationalize this for our purposes is going to look very different depending on the provider and meeting them where they are at. But that is the expectation that those providers who are going to deliver the service are going to have more staff to, in theory, then meet the requirements of this rule. Okay, moving on to the next portion in paragraph D is the availability. So there are two pieces. There's the RN and LPN under the direction of an RN, and then the next slide is going to go into staffing ratios. But the first piece is that the provider has a sufficient number of RNs or LPNs under the direction of an RN on call or on site at all times for individuals receiving memory care. Currently, there is not anything in rule that says this language in bold at all times. So that is a new requirement that we will have to monitor to ensure that there's staffing coverage, whether on call or having somebody on site. Now, on call and on site, those definitions are defined within the Department of Health. So if you're not sure what the difference is, you can go to the Department of Health RCF rule language and look there. But that is an additional requirement that is going to have to be met for this service. So like I said, there are ratios now that memory care service providers are going to have to comply with. There are 3 ways that a provider can meet these ratio requirements. They only need to pick one. Now, for context, we have already received, now it's closer to 40 memory care attestations from currently certified providers. There are 394 currently certified providers, or 396. We've only received 40. Of those 40, all but 2 have said that they are going to meet the ratios through this paragraph I. So right now we only have 2 that are going to be meeting the ratios through, I think it's the number 3. But right now, this is where the majority of our providers are going to meet compliance with this rule. If providing both memory care and the basic service, a ratio that is at least 20% higher than the provider's ratio for its basic service. So if we're looking at staffing ratios, we might be looking at daily staffing charts, calendars, and we're going to have to work with the provider to determine how they are going to meet this 20%. Show us how you meet the 20% more. I don't expect the PAAs to be the ones with all the answers. Providers are going to have to take some responsibility for this, and however they want to demonstrate that is up to them. But we need to feel confident, comfortable using our professional judgment that they can demonstrate the difference between their basic staffing ratios and their memory care staffing ratios. But it has to be a 20% higher ratio. So they might look at that and say there's one more staff member than there is on the basic. Again, there's going to be a lot of factors that we're going to have to peel back and determine to ensure compliance with this. The second option for ratios, nobody has actually said that they're going to meet through this way. So just a FYI, currently we're not facing anybody that's going to be attesting to this, but the next one is if providing only memory care and the average ratio for the basic service provided by a representative sample of providers participating in the Medicaid-funded component of the assisted living program is readily available to the provider. So what that is translated to is that the provider has data to pull a sample and determine that this is the average amount of staffing ratios, then they will take that data and add at least 20% to the staffing ratios on their memory care for their memory care service. Now, I have researched and I haven't been successful, but I don't know where a data set lives for providers to pull this representative sample from, which is probably why we're not seeing providers attest to meeting the rule through this avenue, and that's okay. But just make a mental note that if you have a provider asking questions about where they can find this representative sample, I don't know the answer to that yet. If you have a provider who does have that sample, please document it. I'd be curious to find out where that is. So this one's a little bit unique, and but again, it's not something that we have come across yet in our attestations. And then the third staffing ratio option, if providing only memory care and the average ratio for the basic service provided by a representative sample of providers participating in the Medicaid funded component of the assisted living program is not readily available to the provider, then a ratio of at least one staff member who provides personal care services for every 10 individuals receiving memory care, with at least one staff member who provides personal care services on each floor of the RCF if it's provided on multiple floors. So we have 2 providers currently who are going to meet the staffing requirements through this, where they're just going to have a 1-to-10 ratio, and they'll have to demonstrate compliance with that however they can. So that last part about providing personal care services on each floor, what we are saying is that we can't have 1, 2, 3, 4, 5 aides all on one floor, that it needs to have a 1-to-10 ratio on that floor specifically. Currently, we have lots of providers who are spreading their aides through multiple floors. And for this service, we want to avoid that. We want to ensure that because these are individuals who often require more care or more assistance, that there is a dedicated staff member for that floor. Again, how that looks in operation, we will need to do some more research once the rule rolls out, particularly with the 2 providers who have attested to meeting this. I'll be curious to see how they're going to meet this requirement and what it actually looks like in their documentation and practice. Initial qualifications, moving on to the rest of the rule. So we added additional topics that are required for staff to deliver this service. We really needed to hone in on this because, as we know, there are aides, nurses, other staff who just don't understand the dementia behaviors, the techniques, the approaches, the way to support individuals requires a very unique skill set. So we wanted to put in rule that there are requirements that staff have to have when it comes to their training. So things like just an overview of what dementia is, foundations for effective communication, common behavior challenges and how you can manage those behavior techniques, some current best practices, and then missing resident prevention and response or elopement. There are no total hours for this, but again, keep in mind that every memory care service provider also still has to meet the basic requirements, and that includes training. So they are already receiving that basic training plus this. So the total amount of hours is silent for this portion, but we would expect to see some record of the provider to demonstrate meeting these training qualifications, similar to how we do now with continuing education. Who was there, what was the topic, things like that. We are encouraging providers to take it upon themselves to find the training materials for these items. We, again, are going to ask for feedback on how that's going. If providers need help in finding these training topics, we can work together to figure out how we're going to provide that technical assistance. But if providers are interested in delivering this service, their staff have to meet these training requirements. Now, there is some overlap. We understand that the Department of Health requires that additional training be provided for those providers who are already delivering a service for those who have, late stage cognitive impairment. So there's going to be some overlap with those requirements as well as what's in here. So we are still in the process of figuring out how to put that overlap guidance in a tool for all of you, so that it's clear whether or not the overlap is going to meet our needs as well as the Department of Health needs. So stay tuned for some guidance on that particular piece. And then ongoing training, so in service. So staff members for in service just need to complete the requirements that exist in the basic service in accordance with the Department of Health rules. So this essentially just points back to the basic service section of the rule for ongoing in-service continuing education. So there's not anything additional outside of what's already in the Department of Health rule. Okay, I know we went through that quickly and without time for questions yet, so I'm just going to ask that you hang on a little bit longer. I only have a few more slides to touch on, and then I'm going to circle back in and open it up for some questions. HCBS settings and memory care. The addition of this new service doesn't change your process in monitoring for compliance with the final settings rule. So continue to operate as you normally do with utilizing the tools for the HCBS settings checklist for your internal purposes, sharing that with the provider, continue to interview staff, utilizing those questions, continue to ensure that the provider is aware of what the setting requirements are. Now, with this new service, there is likely to be additional modifications in care plans, and I'm going to be training on that for the clinical team on Friday. So we're just asking that you continue to confirm that the most recent care plan is in the chart. And if you are spot checking care plans, again, just making sure that modifications are reflected and include all of the necessary components, working with your clinical teams to make updates as appropriate for those modifications. Of course, send me any concerns that you have if you need help in communicating that to your clinical team. We're here to help with that as well. Shifting gears real quick, the question came through a while ago about how we're going to reflect this memory care service and beds in PIMS. This is current state where we have non-memory care units, we have memory care units. The addition of the memory care service has nothing to do with the PIMS screenshot that you see here. So regardless of where the memory care service is delivered, it doesn't change the memory units. The memory units in PIMS should represent the total amount of certified units, which it currently does, and that your memory units section is to capture secured units. So I want you to look at this. This is not how PIMS is going to change, but this is just for an example, a visual example, that this is what it's translating to essentially. We have non-secured units at 75, and we have secured units. I don't want you to confuse memory units as being synonymous or the same as the memory care service that's being delivered in those units. That is not what this new service is implying. So because the language is going to stay the same in PIMS, I don't want you to get confused. We are not going to make the language changes right now, given all the other things that are happening. But this is a separate component outside of the memory care service. Months back, I asked for all of the PAAs to send me a list of the assisted living facilities who have locked units and who don't. And unfortunately, that number that I obtained was not consistently reflected for locked units in PIMS. So what I'm asking you to do is over the next year or so to verify that the number of secured units that are certified for the AL waiver in a locked or secured area are reflected in the appropriate box. So there were some inconsistencies across the state. We still want to track that information because from time to time we get asked how many AL waiver units are on locked units. And so we do want to keep that information. So again, this is not changing. This is going to remain as you see it today, but that's just how I want you to think about it when you're asking for additional units to be added or subtracted moving forward. And then again, I just put a quick note here for an example. So if you have any questions about that, I'm happy to go into further detail offline so that we can ensure that you reflect it accurately in PIMS. Okay, so next steps, and some of this was talked about in the notice, but we do have a meeting scheduled on the 19th for the development of the tool for the memory care service. I've asked each of you to send one representative from your PAA provider oversight staff to have a work group to develop the tool for this. So if you can't make it, that is okay. If nobody from your PA can make it, that is okay. Just send me your thoughts so that we can incorporate that into the conversation on the 19th. Once the tool is ready for everybody to review, we'll send it out and solicit additional feedback because we want to make sure that it works for everybody. Contracts will be forthcoming at some point. I don't have them today, but it's on our radar. Like I said earlier, there'll be training for providers that I'll be developing. And then I'm going to work with each of the PAAs to schedule on-site visits for one of their memory care providers beginning in 2024. So just stay tuned for emails from me in the coming weeks to schedule on-site visits. We want to make ourselves as available as possible. You are only going to be successful with the resources that you need. So we will continue to work with you, collaborate. We don't have answers for everything right now, and that's okay. But part of my responsibility is ensuring that I make myself available, that other staff at ODA make themselves available, come on site if that's going to be the best approach, and figure out what the providers are currently doing, what best practices they've already incorporated, and maybe what some changes are needed for the policy and the rule and how we roll this out. So like I said, it's now over, almost 40 attestations received. We sent the notice out yesterday that included both guidance for provider oversight and clinical. I have a clinical training scheduled on Friday that will be recorded as well. And I will be able to share both of the trainings with the entire PAA staff. So you don't have to attend live if you're not able to make it. So that is all I had for my slides. I want to stop sharing my screen, and I know I asked for questions from the notice, but I want to go back to the questions that we received in the chat. So let me just stop presenting. and bear with me as I scroll through these questions.
Meredith, would you like me to read them to you?
That would be great. Thank you so
Okay,
much.
great. Absolutely. Okay, the first question is, does the care plan still need to note that individuals have a dementia diagnosis when there is no lock on the door?
When there is no lock on a door, we would expect that a modification be documented in the care plan. There are 8 requirements of documentation in the care plan that have to be reflected in order for there not to be a lock on the door. Dementia diagnosis does not necessarily mean you can't have a lock. There could be many other health related reasons. But if an individual does have a dementia diagnosis, we would expect to see that all of the other processes were done in accordance with the rule for the modification to justify why that right or requirement was taken away or restricted for that individual.
Okay, next question. This is not a question, but more of a statement. So I'm not sure, Linda, this came from you if you had anything you wanted to add, but it says verifying the attestations providers are submitting. So is there a question of what to do with those attestations when they are forwarded on, or another question around that topic?
That's okay if there's not a question with that, Linda. But just taking a guess here, there's no additional step that the PAA needs to take at this time when you receive a copy of the memory care attestation. I encourage you to just make a note of it. I've already put it in PIMS that it's been received. Providers will be notified officially when their certification is approved. So right now we're just tracking the attestations as they come in. I will be sharing that list of providers in the coming weeks, I think by the 15th or the 18th. I can't remember what was in the notice, but I just encourage you to make a note of it outside so that you know where you need to spend your first 6 months in 2024, because those are the ones that are going to need a site visit.
Okay, moving on. Can individual memory care units or rooms be scattered throughout a facility?
Yes, per rule, they can be scattered anywhere in the facility as long as the provider is going to demonstrate how they meet the requirements that we just reviewed. There are going to be providers who are interested in doing that, and we're going to have to work with them to figure out how they're going to track and monitor that they are meeting requirements for staffing when individuals are scattered throughout the unit. It's going to be a lot of technical assistance. I don't know what that looks like in detail just yet, but per the rule, yes, they can be delivered and scattered throughout.
Will there be a presentation by ODA that will be available for providers on these rule changes?
Yes, I'm going to be developing that after we conclude the clinical training on Friday. I will share that with you once it's recorded and ready.
Is there now a requirement for memory care to have RN on site or on call?
RN or LPN under the direction of an RN. Yes.
And Autumn left a looks like a hyperlink and a chart. I'm not sure if Autumn, was there anything else you wanted to add to the note?
Just when you were talking about average ratios, this is a script study that was done in 2019 of memory care units and SNFs and RCFs, and I don't know if that would be helpful or even following up with those researchers to get that information.
Thank you. It is helpful. I will take that and look into it.
Okay, thank you. Next question. When AL waiver memory care beds are located in different units, same floor, do they need to maintain one aide on each unit?
Depends on how the provider is going to meet that staffing ratio requirement. So I can't answer that because I I don't know how the provider has met that requirement in the first place.
Next question. For the memory care service, when do the additional qualifications have to be met? Must these be completed at hire prior to providing service, like the initial orientation requirements?
So we're going to have to work with providers on that. I don't expect come January 1 that every provider who's attested already to meeting the rule requirement will have every individual who's delivering the service meet this requirement. I expect that we're going to come across some providers who may take, a couple of weeks, maybe even a couple of months, but I would work with the provider to develop a plan of action on how they're going to achieve meeting this requirement. Our goal was for providers to receive this rate increase immediately. And so we are going to be working backwards. Again, this is flipping everything that we know upside down and doing a certification of the service after the fact. So we are going to have to figure out which providers haven't met that requirement when we go on site and determine whether or not they have a good faith effort in place to meet that requirement.
Okay, next question. Oh, go ahead.
I'm sorry, Meredith. So for the initial qualifications, this is Angie Jenkins. The training requirements for like dementia training, there was some additional requirements for training for memory care service for the staff. I guess that's what I'm specifically wondering. It says, is that something that you would like to see moving forward when somebody is hired? Would you expect to see that is done at the time of hire, or is that something that they can do similar to like the first aid training that can be done within the first 60 days, after they start? I guess I just think that's the timeline I was looking for.
Yeah, good question. So after the deadline of, I think it's January 16th, any provider who wants to provide this service will have to follow the normal certification processes, which would include meeting requirements like the staffing training as part of their pre-certification process. So that has not been operationalized completely yet in terms of, at what point in time we'll be looking at all of this, but that would be the ultimate goal, is that similar to other applications, that providers demonstrate that they have met these requirements during the certification process.
Okay, next question. For the PIMS rooms, can this section of PIMS be available for review? It is grayed out, and if there is a long list of rooms, we are unable to see them all.
Yeah, great question. We worked with ISD to expand that notes section, which reflects the specific certified room numbers. And unfortunately, we were not able to get a fix on that. But if you have a need to see all of those room numbers, please send us an email and we will get you that list. I apologize that is not something we can do right now. But in the meantime, just let us know if you need that. We're aware of the concern. It's on a list, but we just can't make that update right now.
Okay, next question. Is there an idea when CMS might approve this, and will there be additional changes to the service and/or rule based on recommendations from CMS?
Sarah, do you have any insight on that?
Good question. At this point, I don't think we foresee any substantial changes to the rule or the rates, but as you know, until everything is finalized by CMS, there always could be changes, but at this time, I don't think we anticipate any. And we would expect those to be approved, as we're waiting on all of our rates to be approved any day. So we would expect it at some point this month, but it could be any day. Okay, next question. When asking to add rooms to an AL, will we need to say if they are secured or not now?
So for tracking purposes, the current form already says memory care non-memory care. If my memory serves me correctly, the process for that will not change. So memory units on that on the form will essentially be your secured units. The process for that won't change.
Okay, next question. With the clarification of the memory units, are we to update it in PIMS or do we still send to ODA for the update in PIMS?
Still send to ODA for that update.
Okay, the next question is, can you talk more about the contracts? And I know you mentioned that more information will be forthcoming as we do not have those today, but Kelly, did you have any other questions about that?
Hello, this is Kelly from PSA 2. Thank you for this presentation. So yesterday I thought I heard that there were not going to be contracts on the relationship call, but I may have misheard. So will these be contracts just for these memory care certified ALs? We will receive some type of template like we always do during contracts, and we will just be having the provider sign this revised contract with the memory care, or are we recontracting every AL for 1/1?
No, I believe it'll be the first thing you said about just specific for those providers who are going to deliver the memory care service who've attested right now. And it will not need to be a full review of all providers, just for those that are doing the memory care service.
Thank you.
Mhm.
Okay, next question. In your example, if memory care is expected in all units, then are all of the units being paid at the memory care rate?
The memory care service is delivered to those individuals who have a documented diagnosis of any form of dementia, and for providers who are meeting all of the requirements. So there has to, it's a twofold, where there's the requirement of the provider being able to meet each of those service rule requirements, and that can only be delivered to individuals who have a documented diagnosis of dementia. So if there is an individual without a documented diagnosis of dementia living next door, then that person would not receive the higher rate for that day.
Meredith, this is Linda Brewer, and I was the one who asked that question. I was basing that on where you had the illustration of like secured units versus non-secured and memory versus, there was like a statement on there that said memory care service should be provided in all of the units. So that's what I was asking that based on.
Oh, sorry, I'm sharing the wrong screen. You know, Linda, I tried to, I really wanted to avoid confusion around this. So my example was strictly in a hypothetical situation. So that note that you see where it says memory care served in all of the units was simply just a way to reflect how you could utilize the notes section for a scenario that doesn't actually exist. So I don't want that to confuse you.
Okay.
So if you have a provider who is only delivering memory care in the entire facility, then you could have all sorts of scenarios where some of those are on locked units, some of them are not. I don't know. But if you have
You're saying it just could be
It could be.
provided in any one of the units. Okay, got it.
Yeah. Yeah. Sorry about that. I was trying to avoid that exact problem.
Okay.
But if you have a question that comes up for a provider specifically, for any of you that you want to make sure you reflect this accurately in PIMS, just shoot me an email and I'll walk you through it.
Okay, can you talk more about the on-site visits? We have many ALs that we are going to in December. Is there anything we can be reviewing this month, or will we need to complete another review?
Good question. I think the reviews that you have scheduled for December already, if you could send me an email of those providers, and I can tell you whether or not they've already attested, which is kind of outside of the process that we have in the notice. But I'm happy to just give you a heads up now, so that you can prepare and walk them through, what they can expect in terms of the requirements. If you have specific questions, I think just providing some general education about where they can find the rule, and tell them that training is going to be forthcoming. ODA will have to make a decision about when another on-site review is needed, because technically in December, they are not delivering that service. And so we're going to want to verify that service is being delivered in accordance with the rule. It might even mean that we push the review back and we give the go-ahead for that, so that we can do an annual review with this memory care rule. So if you have reviews scheduled in December, reach out to me so that we can make a decision about the possibility of just pushing that review back a month or two.
Okay. There is a question about what the 8 requirements are for the no lock on the door in the care plan, and must they all be met?
Great question. The requirements for modification point to a Department of Medicaid rule. Sarah, do you mind throwing it in the chat? It's OAC 5160-01- oh my God, I'm drawing a blank. 5160, 4401, and 4402 are the setting requirements and the person-centered planning requirements, and both of them touch on the modifications. A training that was recorded for clinical team was attached to a notice, talked about each of those requirements in detail for modifications. And yes, all of those requirements that are in the rule have to be in the care plan. We have staff at ODA who are reviewing care plans to ensure that is happening now, and we are monitoring it closely because of our corrective action plan with CMS for setting requirements.
Okay, and those have been added to the chat. Will the provider training be available for all providers or only to those who signed an attestation? Will it be something that we can access if we get questions or have new providers who may be interested?
Great question. I don't know the answer to that yet, in terms of whether it's going to be specific to providers who have attested, or if it's going to be general for all providers. My recommendation is that we start with just those providers who have attested, because their process in meeting these requirements is going to be unique to what's happening right now, versus providers who are going to have to go through the certification process is going to be different. Either way, you will definitely get a copy of that training. You'll be able to access it, share it, once we put some parameters around that.
Okay, next question was again about if we know when we will receive official notice of the new room and board rate. And we do not have a date of when we expect to receive it, but we do expect to receive it at some point in December. And we are pretty confident that we will not see changes in the rate or the rule at this point, but we will keep you all updated. The next question is, so we will be meeting with them for the memory care qualifications on top of the normal SCR, at least for providers who do not have an SCR in the first 6 months of 24.
We might move up the SCR dates so that you can check off both boxes. So we're going to be a little flexible in meeting those requirements for the annual reviews in conjunction with this rollout of the memory care. Again, I know it's not the end of the month. Only 40 providers throughout the whole state have said that they're attesting to this right now. Of course, we could see an influx, but we will work with the PAAs to be flexible in moving SCR timeframes around.
And Linda, I see a hand up.
Yeah, just to go back to that question about the room and board rate, I'm not talking about the reimbursement rate for providers. I'm talking
Oh,
about,
yes.
yeah,
Yep.
the based
Um,
on the SSI rate.
yes. No, I do not have an update on that. So we can continue to follow up on that. Thanks for clarifying. And then I see another hand up, Billy.
Hi, this is Billy from PA3. I just have one question, Meredith. We have 3 of our gardens providers who are all due for reviews in January and have all signed the attestation for memory care. Do you think it makes more sense to push them back and wait a little bit to give them time to get going, or should we just go ahead and keep our appointments for January?
That's a great question. Let's weigh, what is best for the provider, what is best for you as PA and responsibilities. I think that those conversations for all PA should happen, and we can talk further about what's gonna just make the most sense, because again, we want to be flexible with this. We understand providers might need some time, so it might even include calling the provider and getting a sense of whether they need a little more time to implement the service or not. But we're open to rescheduling. So reach
Okay.
out to me, Billy, and we'll talk more.
Okay, because I know all 3 of those providers, I don't believe any of them have a secured unit. They hadn't done memory care before, so I just wonder if they'll even be providing the service yet by the time we do our review.
Good point.
Okay, thank you.
Mm-hmm.
Okay, and I know we are past noon. We can still continue to stay on and answer the last couple of questions, but I just wanted to alert everyone to the time. The next question is, do we still need to complete the approved room list?
Yes.
Okay. Next question. Would you please send PAA4 the updated spreadsheet when requesting new units to become certified?
Yes.
Okay, and then it looks like our last question. Is it just the providers that we receive the attestations for that we need to make sure that we review in the first 6 months?
Yes.
Well, that was very easy, the last few questions. So, Meredith, that's all we have in the chat right now, and I don't see any more hands up.
Okay. Thank you so much. So continue to email me questions. This is going to be an ongoing conversation, and ODA is going to develop additional training for providers. We are, going to be following the deadlines that are in the notice. If you have questions, concerns, this is not, again, your only opportunity to reach out for help. But again, the goal is that we get this rate available to all the providers, and then we're going to work a little backwards and make sure that they're meeting all of the requirements. So I appreciate your patience through this. I know this is a big change, but again, it's going to meet a lot of good things in the end as we continue to learn how the best way to operationalize this is going to look like. And we're here to work with you and work with the providers. So if I don't talk to any of you, happy holidays. This recording will be shared as soon as I can get it uploaded and put on the WAN, and I will let you know when that's available, as well as the PowerPoint. So with that, thank you for your time today, and have a good rest of your day.